Hello everyone, David Wilson here from Dr. Stem Cell. In this video I am going to be taking my glasses off and putting them back on to read the text on the screen, simply because I'm sure you can see it's very disturbing to have these big reflections. I apologise, new lights, and I didn't think it through, so the new lights give me terrible reflections. So we'll start the video. My name is Dr. David Wilson. I'm the stem cell regenerative medicine doctor here, and I am interested in sharing with you research and findings, trying to get up to date, trying to teach myself and therefore share that knowledge with the world about PRP, stem cells, regenerative medicine, therapies that don't involve pharmacology. As we go down here to page 5 on the document markings, there we go, and that looks pretty good. Yep, we can all see this. We've already discussed PRP versus placebo, and we've discussed PRP versus hyaluronic acid. PRP versus exercise, let's have a talk about that. I was surprised to discover that there were so many high quality studies included. There were 4 high quality studies that have looked at this, plus 1 moderate quality study. And when we look at the total number of patients, we can see that it included 201 patients. So that means your average number of patients included in these studies were probably somewhere between around 40 to 50. 40 obviously if you're counting 200 divided by 5, sorry. PRP showed a statistical improvement, slight statistical improvement. It's hard to know because we're going to look at this in more detail now, but the statistical improvement in outcomes when compared to WOMAC in one study, for SF36 in one study, that's quality of life score, WOMAC function-related patient outcomes in one study, and for VAS pain scores in one study. 3 studies reported no statistical difference in the function stiffness pain score that patients reported, and 2 studies reported no difference in WOMAC pain scores when PRP was compared with exercise. In one high-quality study, PRP resulted in statistically significantly better WOMAC pain scores at 6 months after treatment. That's about in keeping with what we'd expect from PRP. So to summarise, while there were some studies that reported better patient outcomes with PRP when compared to exercise, there were also studies that reported no significant difference after PRP injection when compared to exercise. Additional research comparing the use of PRP to exercise therapy, as well as a combination, may yield more clarity. I have a few thoughts on this that I think I would like to share with you today. In my clinical practice, we see patients often who've come to us because they've tried physiotherapy and training on their own for a while before they come in, and at that point they then will complain of saying, I feel like I've plateaued, I'm not able to make more progress, my knee's getting worse, and I've kind of done everything I can and I'm stopped. This is a fairly common complaint for people who are already active. On the other hand, a lot of our patients come in and they tell us that no, they haven't really tried training, they don't like training, they don't want to. And for those patients, I usually advise that one would begin with exercise, weight loss, and maybe physiotherapy, because there's a lot to be gained from getting in better condition, not only from a knee perspective, cardiovascularly. When we look at these papers then, we do see an encouragement that PRP ought to give people more improvement. However, some of the things that would need to be more clearly outlined and defined would be the exercise status and the cardiovascular function that people have, their fitness level, their function level before and after. And I know we see improvement in those scores, but if you have someone who is virtually immobile or very limited in how much they exercise, how much they really use their knee, you're going to see probably a larger expectation of improvement with exercise already. And then once you've plateaued, that would be when we would recommend putting the PRP in there as well. Now, that's not to say that people with established joint arthritis shouldn't be considered for PRP. They absolutely should. And if they don't want to exercise, if they feel like they can't, if they're otherwise struggling, that's when you would want to recommend PRP. Bear in mind that these videos are not medical advice, but they are just a look into how we look at patients and how we make these decisions. I think it's very interesting. So my general go-to answer for patients who come to me with knee pain, if they're not active, is try and get active, give that 3 to 6 months, see how it goes. If you don't improve, then we talk about PRP. But of course, in many cases, patients say, I've already tried, or I feel like that's too difficult, I want to try PRP already. And in that case, you have to make a case-by-case decision. I hope this video has been useful to you. I've enjoyed looking into these subjects. The next video we do will be on corticosteroids. It'll be a little bit more in depth, because in this video we're going to have to look at how corticosteroids work first of all, and then compare them to PRP. We'll see you then.